hard feedback. My name is Terry Evans. I'm the president of Employer Advisory Services, and I want to welcome you to our first panel of our Innovation Conference. This is a story that is near and dear to a lot of people's hearts that are in this room, but the first thing we're going to do is go down this line and allow these folks to introduce themselves to you. We'll start with Karen.
Hi, everybody. I'm Karen Nacarado. I'm with Cheryl Morgan. Also retired from Bartlett City Schools, which is one of the things we're going to discuss.
I'm Frank Stockdale Carney. I'm the attorney for the interlocal that you'll hear about today.
My name is Teresa Winter, and I'm the recently retired CFO of Bartlett City Schools and worked on the trust when we formed it.
I'm Mark Morgan, president of Cheryl Morgan, and they won't let me retire.
We're so mean to him. We wanted to tell you a really great story. We talk about innovation a lot at Cheryl Morgan and EAS, and we talk about creativity. But you will not hear a more creative story than this one. This is a group that these folks represent several of the school systems that are in Shelby County, Tennessee. Shelby County also houses the city of Memphis. Memphis City Schools had a huge school system, 2 times the size of the rest of the Shelby County school system. In the early 2010s, Memphis City Schools decided that they were going to give up their school charter and turn all of their schools over to Shelby County. And they basically said, here you go, it's all yours. So you had Shelby County, who was a much smaller entity, absorb this huge entity. As Karen said, it was kind of like the guppy swallowing the whale, and they were working together to try to provide schools for all of the children in Shelby County. This went on for about a year, and then several of the smaller municipal governments in Shelby County decided that they really wanted to form their own city school systems. And Frank will talk a little bit about what it took to do that, but they did form their own school systems. They did have to develop programs, and part of what they had to develop was a benefit program that was at least as rich as what the merged system had that could not be less benefits. And they had no money to start with. They had no employees to start with. They were starting from scratch. How do you hire bus drivers? How do you get school custodians? How do you hire folks in finance? How do you hire your teachers? How do you hire all of these things when you've got smaller school systems on their own? So the decision was made to try to come together as a cooperative purchasing originally, and then come together to get health insurance. So this is the story of this group. Now Teresa, being the CFO, and being one of the original folks that was out on her own trying to make all of these interesting things happen, what made you realize that a different approach to a health plan was going to be necessary for this group?
Well, it wasn't really a decision. It was our only choice. And it didn't happen right away. One of the things, let me just say, we started the school district. My boss was hired around the first of the year. The superintendent was hired around the first of the year, as were the other 5 municipal school superintendents. And I think almost every one of them, the first person they hired was their CFO. Since I was working in the merged district, my boss there told me I had to give a 2-week notice, so I didn't come on board until January the 27th. We had until July 1 to do all the things that Terry just talked about. We inherited the teachers. We were going to be able to keep them in our schools that we had, but everything else, we had all of our central office staff, how we were going to handle transportation, how we were going to handle everything had to be decided. So the first meeting that, when I came on board, the superintendent from Collierville Schools and the CFO from Collierville Schools, the 4 of us met, and we're talking about something called shared services. Because all of us that ended up in the municipal school districts had worked in the legacy system. And we all knew what their gifts and their talents were. But the thing about it was, there was only one benefits coordinator at that time, or benefits supervisor. There was only one payroll person. There was only one person that knew how to route the buses. So what we did is we created this plan called shared services, and it worked through, everybody had interlocal agreements. So as Bartlett, we took on purchasing and payroll. We also did employee benefits. We had the planning, and there was a small IT that existed for a long time, because when we broke away, all the IT was still running on one system, like we had been the legacy system. And there were only one or two guys that knew how to operate all the IT stuff. So originally it was just going to be Collierville and Bartlett, but some of the smaller school districts, Lakeland particularly, had only one school, and it was an elementary school. And he said, hey, you can't steal all the people, you got to share them. So we worked out a plan how we were going to coordinate that. Karen coordinated all the benefits for all 6 districts. I think our payroll person had it the worst. She coordinated payroll for all 6 districts. So on every payroll, she ran 6 different payrolls, balanced 6 different payrolls. So there was nothing we were doing at that time that was conventional or that was tested. We were going on our own, because at that time, there had not been a new public school district in the state of Tennessee in over 50 years. So there was no roadmap. We were creating it as we went. And like I said, we had to call upon the knowledge, because we had 6 months, less actually, to get it up, to pull 6 municipal school districts up into operating and be able to start school at the 1st of August. So the superintendent started meeting and divvied up duties, and the CFOs started meeting and divvying up duties. What we did best, we worked on, and we shared it with the other 5 in the group. Worked for the superintendents and it worked for the CFOs. Then it was, we were looking about 2 weeks out from payroll. And all of the CFOs were together. We wanted to make, because we also had to get a computer system up and a general ledger up and running, and purchasing and all of that ran through the computer system. So we had to make sure that that was working. So about 2 weeks out from the payroll, when we started making employee benefit deductions, the CFOs got together and we said, we just want to make sure that all of our ducks in a row, that everybody's going to get paid, that we're going to get the money pulled out. So we're sitting there, and all of a sudden somebody says, well, we've got this nice plan that we've developed, the employee benefits, but where's the money going to go? And we all go, we don't know. And Bartlett at the time was the largest school district. So they said, Teresa, you need to handle all the money. And I said, oh, no way am I commingling all those funds under my purview. It's just not going to happen. So I thought, I had a contact at Regions Bank, and this lady had gotten me through a lot of battles in the merged district. Won't go into that, that's another long story. But I called her and I said, hey, we're going to be deducting all these employee benefit premiums from our employees' checks. What do we need to do with them? And she says, oh, you need a trust. I said, okay, how do we get one of those? And she said, let me toss you over to our trust department. So I started talking to the people in the trust department, and they said, well, it's going to be, probably the minimum time we need to get one of these things set up is probably 4 to 6 weeks. I said, I've got 2. He said, oh. So Frank had to undo a lot of stuff that we did, because we ended up, we opened an account in the trust department with the tax ID for Bartlett City Schools. And Karen and I were talking about it last night. We're not real sure whether it was my name or the superintendent's name that went on the paperwork, but we got that done, and payroll ran, and we had money in the bank. And so it wasn't really a choice how this thing the trust got formed. But we worked with Mark, and we worked with Cheryl Morgan, the cities came on board because a lot of them were seeing, double-digit increases in their fully insured product, and they were saying, we can't sustain this. So we had all of another meeting, one of the first that I went to, we had all of the mayors, we had all of the superintendents, we had all of the CFOs that were hired at the time, and we had all the chairmen of the school boards in one big room, and we said, hey, Mark was there, he presented this plan to pool all of our resources, because none of us, Bartlett was the largest, we had about, I think about 300 or 400 teachers, I don't remember the exact numbers, but none of the districts were large enough to sustain self-insured on their own. And the only way that we were going to be able to do it was to pool our resources and get it together. The state had decided within the legislation that they passed that allowed us to form municipal districts, there could be no diminution of teacher benefits. And at first, we thought the easiest thing was do is we just get everybody on the state insurance. State came back and said, no, that's a diminution of benefits for teachers. You've got to do something different. So on top of all the other things that we were dealing with, then we had to figure out how we were going to do benefits blended. And it happened. We had our first meeting. The general counsel from Bartlett showed up. Thankfully, I asked her to come, and she says, you guys need an attorney, and it's not me. And so I think probably all of the general counsels for all the school districts had probably gotten together and recommended Frank, and he kindly came on board and untangled my mess that I had created, so.
Well, thank you. Now, Frank, since we're talking about the development of this trust, I'd like to hear from your perspective, what exactly happened and how did you fix it?
Well, there were nine, and I don't think you were told that. There were 9 entities that we're talking about here that were getting together. 5 of them were the municipal schools. 3 of them were actually city governments. So my background through the evolutionary of my practice is employee benefits, and I largely do it for cities and counties. So at least I had that sort of experience, not with, this obviously was a unique situation. So we needed, they started out with shared services, but if we're going to have a pooled fund and you're going to have a structure that's going to work like this, you needed an entity. And so that's what we started looking at. Fortunately, we had legislation that allowed for multiple governmental entities to get into an interlocal agreement, is what we call it, and that's what we call this entity, to get into a joint agreement about how they share services, and that's the first thing that was put in place. So 9 attorneys got together, and each one has their own individual client, and each one has their own individual, instructions on how to do this, but they got together and negotiated out an interlocal agreement where the 9 governments could work together in a joint venture, for lack of a better word. So none of the 9 attorneys were employee benefits, so they then were looking for an employee benefits lawyer. I always tease that that's probably the only situation that ever happened in my experience, is where 9 attorneys agreed on one person. Now, how they did that, I don't know. But yes, I got a call, a conference call. This was really before we had the virtuals and all the things we have now, with 9 attorneys, and they got on and told me what they needed. To pool these funds, obviously we needed a single trust, and you needed a structure in that trust where the parties could agree on how to operate. So I began having meetings as to that and how they would, who was going to be the trustee, who was going to be the instruction. We formed a committee, and that's the Health Benefits Committee is what we call it. And there's a structure for that and agreements on that, voting powers and all those things that had to be negotiated, so we negotiated those. The stress of the time was when they called me, it was a 2-week period of time, and at the end of really on the 13th day of that 2 week, I had already planned, I'm kind of an extreme backpacker, to be gone for a month hiking in Tibet where there's absolutely no connectivity. So I was going to be gone. So I had 2 weeks to get this trust structure, which we did. But it was as you imagine, a full-time, only project you do for those 2 weeks to get the trust structure. So we did get the trust structure, and we got an agreement as to how contributions were to be made to those trusts and what happened with those contributions, because it is a pooled trust. So the contributions come in from all 9 entities, but you're paying the claims of any employee out of that entity. So we had to work through those processes, including processes of what happens if this trust terminates, how do you disperse that money since it's come from different governmental entities. So that was the challenge of getting the trust structured and how we worked on it. And then I was gone for a month, no connectivity for a month. I was on a 160-mile hike in the Himalayas. And when I came back then, we formalized what is now the Interlocal Health Benefits Committee, which we had a statute in Tennessee that allowed us to have a local governmental joint venture, which is a single entity. So that gave us a single entity now that could function with the shared funds separate and distinct from each of its individual members.
Okay. Well, now, Mark, your part is very interesting in this story. We have the trust set up, we have all the entities together, and they need to provide benefits that are as good as or better than what they had before. So they come to you, and what did you do?
I panicked, primarily because the time frame they had given me, and how I even got the job was quite innovative. It was not, they weren't really being completely honest with me, is really the truth. A city down there, the city of Bartlett, had decided that they wanted to hire a new consultant, and that Bartlett knew what was coming in the future, and so they said, well, we just ought to try the guy out before we really give him the big job. So they invited me down to interviews to get hired in Bartlett, and I didn't know, I knew a couple of the city managers from down there for going to conventions, and you get a phone call, and I didn't have any business in Memphis. And I thought, I'm going to go all the way to Memphis and they're going to interview me for this 300-person town. And I thought, yeah, okay. So I went down there, and they asked me about self-funding, what could be done, and to be hired by the city of Bartlett. But then they started asking me questions about, can we all join together and do this? Have you ever done it before where governments got together and joined together and stuff like that? I thought, well, yes, but all those governments had employees. Northern Kentucky Public Entity Group was one of the first pools we ever created. But the difference was those cities already existed and they already had employees. So there was another man in the room, was another consultant they had hired to help them with everything else. And at the end of the interview, he turned to the mayor and said, okay, this is your guy hiring. And I thought, well, that's a pretty cool way to do it right in front of me. Except I was getting hired to be the consultant for this soon-to-be health plan. So I started going to work, and Lisa Stam, who's our staff attorney, we all started making phone calls and stuff about how, who's going to insure a group we don't know the population. They said they were going to inherit the teachers, but what they didn't tell us is what teacher was going to go where, under what school system, and on what date would they start, because they all started at different dates. And then they decided that, well, maybe we don't want to hire that teacher. So I ended up having no health experience, and I tried to get it from the county. Yeah. I think if even if they had found it, they wouldn't know what to do with it, because he had been with Cigna. And then they set down some ground rules for me, I couldn't go get their health care from. I couldn't go get their health care from Cigna and Blue Cross. Okay, I can't go there, so that's fine. I didn't mind that so much, except that who was I going to go to? So I started going to third-party administrators and trying to find somebody that would help us out. No one could underwrite it. So then we'd actually do something that was innovative, and we did community rating. We said, we're just going to take, since we're talking about several thousand people in a pool, we're going to take the average healthcare costs of the city of Memphis and the surrounding area and its populations and create a community rate. So we created a community rate, and then we had to go find a stop-loss carrier to we call it take in a flyer. Here's the community rate, this is what's going to be charged. Will you protect us against loss? And they said, yes, we will. And then they asked a really interesting question. What's the asset level going to be at the start of the health plan? How much cash are they going to have on hand? Oh, none. No cash? Yeah, because normally you start a self-funded plan, you start with cash. There was no one to collect cash from until they actually existed. And so then we started a health plan. We've got actually a corporation of Aetna to protect us. And and we got that started with no cash, started the health plan. We inflated the rates a little bit to create a claim lag within the rates, and off we went. And for the first 5-6 years, it was touch and go. And there was one day the state auditor came in and wasn't very happy with us. So not only did we have to start the plan in an innovative way, we then had to continue to be innovative in order to get the thing to work, because we had no money, and no one was going to offer us any more money than what we collected from the budget from the premiums and stuff like that. And we had to make a plan that was the same as the prior plan that they had, which was really crappy, quite honestly. And we will kind of hear, I guess, in the rest of the story how that evolved. But yeah, we all went around together to all the different school systems, all the different board meetings, and presented this for, it was like the craziest road show I've ever been a part of. And they finally decided, yeah, okay, let's do this thing. And off we went, and we used an Aetna network at the time, and Aetna provided the stop loss. And that's how it kind of all got started in the game to get this thing off the ground.
Well, and Karen had the joy of being the benefits supervisor for this trust with no money and no real plan in place. So tell us how that all came about, and how did you know that innovation was going to be the way that you needed to go?
So Teresa had the luxury of being hired around the 1st of January, and Mark being the consultant around that time too. But I wasn't hired until April the 1st, and that was when they had already started looking at benefits, and I knew that I was going to have to figure out how to provide benefits, enroll people into benefits, deduct benefits, and make sure people got ID cards by the 1st of July, because that's when the plan initially took over for the central office staffs. The teachers, thankfully, they had a little bit of time. So the easiest probably at that time was just to mirror the plans that the school districts already had. It was just easier just to, because we couldn't diminish their benefit, we couldn't provide anything less, and you would assume that the state might be a viable option, but couldn't go to the state plan because the benefits were less. The benefits provided for the merged district were very rich, but they had multiple plans and all of these rules. And anyway, so it was easier to do that, but the challenge was the trust, the group of the consolidated trust was probably about 3,100, 3,000 employees. And the merged district where they had come from was 13,000. So trying to provide a benefit that would match in premium and benefit for such a smaller group was a challenge. The only way that was going to happen was through innovation. So, Mark, Cheryl Morgan, with their, out of the box ideas. I've told Mark this a number of times. Any other consultant would have delivered the group with standard Cigna, or not that I have anything against them, but that type of a model where you have a discount. Any other consultant, that would have been their suggestion, and the city in a year, once we failed, would have welcomed us back, with our tail between, our legs, but that didn't happen. And so, July 1, we enrolled people, we got benefits issued. American Fidelity was a blessing in order to get all of the people enrolled in the benefits and got ID cards by September 1. And then, over time, we moved away from some of the, we initiated direct contracts with the hospitals. We went to a different pricing model, reference-based pricing, so we were able to get a much better payment on their claims. Breaking out the pharmacy. I'm trying to think of all the things that we did over time. It wasn't a quick process. You don't build that amount of reserve overnight, but slowly and surely making those smart decisions. Sometimes they were painful, but making those smart decisions to benefit the employees. And today, I actually compared the plan that the state offers compared to the plan that we offer, and it is not even, the state plan is so much less. And even the current plan with the big school district, we do truly have one of the best plans in the state, and proud to say that we've had very low increases on premiums, and the employees are benefiting from, we've got, now we've got employer-sponsored pharmacy, we've got health clinics, the employees can go to the clinic, doesn't cost them anything, they can get their drugs at our pharmacy. We're looking to expand all of that, so, it's just amazing, and I'm just proud and thankful that I was able to be a part of it.
If I could add to Karen's comments there, the other things we struggled with is that there was a hospital war going on in Memphis.
Yeah. Still is.
There was.
Oh, big time hospital war. And the two hospitals said, well, you have to use a network that we're in and the other guy's not in. So we tried to do a direct contract with both of them, and when the one hospital found out we were going to do a direct contract with the other guys, they not only did not do a direct contract with us, they removed themselves from the networks that they were a part of that could support both hospital systems. The one hospital system was trying to force us into Cigna. So we had a political battle going in the community, and Cigna was like coming to me all the time trying to say, this is what you're going to do, this is what you're going to do, this is what you're going to do. I mean, literally dictating to me what we were going to do, because otherwise we would not have Methodists. So one of the most innovative things we did, and it was probably the riskiest thing we did, is we partnered with the other hospital. Yep. Terry has a job today, by the way, because we did that. I'll tell you that in a minute. We partnered with the other hospital, and we said, we're just going to pay, told the group, we're going to pay Methodist what they know they would already accept. And if they accept it, they accept it. If they don't, they'll balance bill the member. And we'll say, we'll tell the member that could happen, and we're going to steer people away from the other hospital into the hospital in their community. That was actually in their community. And it worked. It worked. Today, we pay every single claim that goes to the other system that fought against us, but vast majority of claims, well over 90% of the claims, go to the system that partnered with us. They partnered with us. We had to get rid of Aetna. We had to move to third-party administration. Maybe I helped that move just a little bit, but Aetna really wasn't doing the job they needed to do administratively, because they couldn't work with that kind of plan. So when we moved it to a third-party administrator, we moved it to one that had the ability to do direct contracting and can manage that. And and at that time it was a company I think called HealthScoop. They're now owned by United Healthcare, so we ended up leaving them. Right. But the direct contract was such that the hospital said, we like this direct contract idea, and the contract was based on Medicare Plus rates. And they said, we like this, but we don't want to just do it for the schools. We want you to do it for the community. And I said, well, okay, but I'm a consultant. They said, well, if you can't sell it to the whole community, then we're not going to do it. So I thought, well, okay, give me a moment. And so we created another corporation called Employer Advisory Services, EAS. And EAS then works with hospitals, and EAS was able to go to every agent, every broker in the community and say, here's a new network offering from the Baptist systems in Memphis, which is now our partner in cooperating with Memphis. And that got us in the hospital business. That business has blown up, and Terry's now the president of that business. So that's part of the unique stories that go behind the scenes that you don't really know or hear about sometimes, of why how did we go? Now we started off about a $35 million plan. We're now almost a $60 million plan. Yeah. And over that time frame of the beginning to now, they've had flat increases for almost 5 years. Their RX exposure has decreased by 19%. Their RX costs have gone down by 19%, and every member has a copay. Every member, no large deductibles, no HSAs, just copay plans. Because when we started managing the internal operations of how the insurance company actually worked, and now when I say insurance company, what am I saying? The trust has become an insurance company. It holds all the assets, it holds all the controls. Every piece is segmented out to a contract so that they can plug in and pull out any particular piece that they want to. And it's not contingent on any particular third-party administrator, any particular hospital, or any particular pharmacy deliverer. And we could go really into in fact, we're going to go into some of the weeds of some of this stuff, particularly how come we open a brick and mortar pharmacy, how come we open health and wellness centers, and that kind of stuff in other sessions. But
Well, now, Karen and Teresa, since you were boots on the ground, since you were the ones who actually put this together, what advice or little nuggets of wisdom would you give to others that are looking at becoming self-funded and they may not have the adequate reserves that they would need, or even if they do have cash on hand? What would you tell them to look for and to evaluate when looking at self-funding?
Well, my first piece of advice would be don't do it in 2 weeks. Take your time. It really was ideal, but it was it worked for us. Thankful we had Frank to fix it for us.
Well, I was just going to say that don't be afraid of change. Don't be afraid. Don't accept the status quo. Don't, if you're fully insured, don't accept that you could never be self-insured, because there are protections available. I mean, obviously, because we went from zero, so there are protections available, for those that are wanting, but the benefits so outweigh the risk. You have the flexibility to provide benefits that you want to provide to your employees, give them the opportunity to enjoy good health, and do the clinics, your employee-sponsored pharmacy, all of these things that other employers dream about, you are able to do. Just don't be afraid of change. So,
That's a hard one, though, isn't it?
I can comment too is that this most of the time I think you might be used to dealing with organizations where there's 2 or 3 decision makers. There's a decision maker for every partner in the trust. So we have board meetings about every other month, and everything is discussed on a financial basis. So literally, in fact, the Monday after this convention, I'm flying to Memphis for our work session on Tuesday. And all these, well, she'll no longer be there, we'll miss her, but because she had to retire. She's retiring famous, though, at least. She did down there. But it occurs to me, that we get hired by organizations with United Healthcare, Blue Cross, Cigna, and Aetna all the time. And they want to come in and solve the problem. And we know whether or not we're going to have a really good long-term customer if after about 2 or 3 years they begin to realize, and we talk about things they could do, and then we just let Aetna and Blue Cross, United Healthcare say, no, no, no. And all of a sudden they go, well, how can I do this? They say, well, you have to be willing to get outside the box. And they say, but our employees like the Blue Cross Blue Shield emblem on their card. I said, which do you think they would like better? The Blue Cross Blue Shield emblem on their card, or to pay less for their health care? And then they start making the right decisions. So stepping outside of that canned situation that we're in America, and it's not there's not a place for these organizations. There is a place for the Blue Crosses, United Healthcare, Cignas, and Aetnas. But anytime you can step outside of those situations and do it differently, that's when it really gets to be meaningful, that the employees pay less for their health plan, they have co-pays, they have over $22 million in reserves. That's considered a fully funded situation, even though they spend almost $22 billion. The actuaries tell us don't accumulate any more right now, accumulate more in the future. So we're in a great situation there, and it's because we did things differently.
I do think that I was a self-funded employer as well. I went from fully insured to self-funded in my previous life. I think one of the pieces of advice that I would give is when you're planning your budget and when you're looking at how you're going to structure your plan, everybody in HR is absolutely inundated and overwhelmed with all of the work and all of the things that you have to do and all of the, we used to call them whiny babies, but all of the people that have problems and want to come in and, create more havoc for you. Budget a benefits person in your self-funded plan. Have your self-funded plan pay for a benefits expert, a benefits specialist to handle that. And that way someone is keeping on top of it. Someone is helping, someone is evaluating, someone is researching. That was one of the best decisions I think we made, was actually making sure that we had a position included and it was going to be paid for by the health fund. And if you're a government, you can set that up as either an enterprise fund or an independent fund so that all of the money comes in and it's separate and it has to pay for itself. So it's one of the things that you can do as well. So we're going to open it up. If you all don't have any other comments, we'll open it up to questions from the audience. Is there anyone out here that had any questions for any of the panelists? Okay, I am attached. Okay, I can go. Okay, thank
Kay's
you.
going to come with a microphone there.
I can take it.
Super great discussion. I was curious about the decision to not use tax advantage accounts. If you could elaborate a little bit more on the no HSA, I have to say that I'd love to learn.
No, what was
The no HSA.
Oh, no HSA.
The no high deductible plans.
HSA. Within the space we are in, within the government space and school teachers, HSAs within the state program were considered the basement plan because of the high deductible, and there was no asset contribution by the employer into the HSA. Also, the income levels within school systems vary dramatically when you talk about bus drivers to administrators. So it was a very diverse income situation. And if we had put in all HSAs, in this particular instance, the state would have considered that a diminishment of benefit, and they wouldn't have let us do it and all. But now going forward, we've done the math a couple of times, in fact, to say, is it worthwhile to put in an HSA now within the universe that we exist in today? And the irony is that it doesn't look like it would. There are a handful of people in the organization, a handful, maybe there's 100 within the 3,500, that would benefit because of their financial levels that might be a tax advantage for them. But we're getting so much more power from directing care to the places that we want it to go, and we're getting so many direct contracts that we're got such a handle on our inflationary situation that the HSA has not really been necessary. We've experimented putting in a couple of our private industry plans, and for the most part they're being used appropriately, but what we are finding is that outcomes are not improved. In fact, they are diminished. If we're talking about a type 2 diabetes population within a blue-collar income situation, we're finding that all of a sudden adherence is not what it used to be. And in fact, in all of the drug situations, when we talk about HSAs, when we studied it, adherence does not stay there for maintenance conditions like it used to when it was, when there's so many drugs, the way we acquire them is so great, so much less than the way they are normally acquired, that sometimes we're actually giving those drugs away to get people to go that route, to use that route for the drug. The number of drugs that have zero copay on our health plans now is really growing almost every single day because we'd rather them move to that substance than use another substance. And later on, it makes me want to talk about something else, but I'm not allowed to right now. But an example of, like, right now, a lot of health plans move people toward metformin because that's an inexpensive drug. With an HSA, it saves people money for that metformin. But metformin has a problem, and that's the problem is it never cures type 2 diabetes. And that's going to be talked about later on. So we're finding that HSAs are appropriate within certain business models or business types because they have an income that they can force into that HSA and take that tax advantage. But anytime you have a diverse population, we find that it's not really as useful as it should be.
Okay. Are there other questions? Yes, sir. Right here in the front.
How do you balance, in a situation like this where you're outside of Blue Cross United, Cigna world, the desire of employees for choice and network and pharmacy and all of that, which Blue Cross talks about how they have these huge networks everywhere, and is that, like, how do you balance that? How do you structure it? Has that been an issue?
Well, no, let's just, except for the Methodist situation down there, the other hospital situation down there in Memphis, where we have some guardrails, our network is actually larger than Blue Cross's. You say, how can that be? It's because we have so many physician groups that, we have a direct contract with in Memphis because we're a mature plan, they know who we are. Like I said, we're an insurance company now, that they make an agreement with our insurance company. But then they're going to step outside of that. We use two different models for when we step outside those contracted situations. The first is our administrator has a policy of paying what's the normal community payment schedule for that for that physician group, because we know what they're accepting for the most part. And then, and we know where people outside of area, students and stuff like that are going. So we just do what's called single case agreements for those providers or those areas or something in that area and continue on and treat them as a network. We never tell a member that you can't go there. Now, the trust has made a few decisions. They decided to cut a few providers off because of certain practices. But outside of that, there's nobody told you can't go there. We negotiate the rate after the fact, and then when you're outside of the area, we're just negotiating sometimes ahead of time. But for major case situations, a big single case, we single case screen it. So really, there's not had a situation where somebody's come to us and said, I can't go to the doctor because you're not in my network. We don't have a network. And then we do reference-based pricing outside of that. So we take what's called community rating. It's a kind of a community rating, what that doctor normally accepts anyhow. And if we don't have that for some reason, we go to reference-based. If the reference-based organization decides they want a balance bill, then we negotiate the balance and pay it. And that still has caused a reduction in the cost. And it also puts a burden on the administrator. So you got to make sure you have an administrator that's used to working outside of the BUCA networks or the national networks. We operate other corporations. We have another corporation, Meyer Tool, that's a national corporation. They operate exactly the same way. They also don't have a national network. It really, it's a lot about the administrator you have and what they can do. And then we've got Terry in AAS, and she spends many days of a week doing nothing but getting agreements with providers. We do the same thing here in Cincinnati with the St. Elizabeth system. And we have other agreements with other facilities too. And also it's really it's just one of those things, you don't know it until you know it,
Other questions? I can't really see, but I don't see any other questions. Well, thank you. Oh, yes, one more follow-up.
Sorry, I'll ask a
That's okay.
follow-up. Can you say a little bit more about out of geography and how that, how that works when somebody's traveling, somebody's on the other side of the country?
Yeah, it travels easily because it's just a travel policy that we use as far as, not a policy we buy, but a practice of how we're just going to pay because they are traveling out of areas, something like that. If they had a major service issue, like they compound fracture at an emergency room and you're in Orlando, Florida, which is what we have happen all the time. We actually know enough about those facilities in that area that we're calling them up right away. The third-party administrator is calling them up right away and negotiating the claim. And there has been a couple of times where we lost the negotiation and we just had to pay the daggone claim. But still, the volume of those is not significant enough to really alter or impact the plan. On a national basis, once we know those people are there, then there's outreach to those providers that they're paying. And we're talking about normal, everyday practitioners, just your regular MD, your family doc, something like that, or the urgent care at a hospital that's being used by a college student. Those are really not our problem situations. They're billing us at a rate, often they're billing us at a rate we're willing to pay anyhow. And all. So it's only the really big outlier situations like the compound in Orlando, or they want to go to Johns Hopkins for something, and we'll negotiate that with Johns Hopkins. They want to do the service, we want to pay for the service, we just want to figure out what price we want to pay ahead of time. But Karen, I can't call it a major complication.
No, in fact, I think the concern initially was because, members are like used to Cigna and stuff, and so it's like, well, what's going to happen whenever they go to the doctor? There was a little initial learning curve from the providers, but the Baptist logo was on there, and so the provider knew that they accepted Baptist, and so, honestly, there was very little, comment from members about, I've lost my doctor. Obviously, that's a concern initially, but, once we told them, if your doctor's in this network, because we had all these direct contracts, that was the benefit. We had all those contracts in place, advance of, issuing the benefits and everything to everybody that, very little. And obviously now we're, 10 years out, nothing, so. Yeah.
And I have to say, communication was a big deal when we first started because it was a new concept, so employees had a lot of questions. And I have to say that Cheryl Morgan was very supportive. We had employee meetings. It was just a lot of communication. And now, like you said, Karen, we don't hear much of that anymore, but that communication was really key.
Yes, sir.
First of all, congratulations. My question is twofold. I think healthcare in the United States is probably the most expensive in the world, and what you guys are doing is fantastic.
Well, the difficulties in the U.S. market space are you have more than one approval methodology for a device to be used, and the last one has nothing to do with the federal government. Is that United Healthcare or Blue Cross want to do business with you? And most of the time, the answer to that is no. Or in the health plans that they manage, they don't want to build it and put it into their systems unless they take years and time to do it. I mean, not that they don't do it; they have done it, and it doesn't happen all the time, and it doesn't happen very quickly when they do have these innovations. I think what the marketplace is blowing up is exactly this marketplace of independent third-party administration. And the BUCAs do play somewhat of a role in that because some of them are now leasing their networks if they want to, and you can use them in those situations. But even then, we don't see those coming in at the same dollar value of just having the direct contract situations working. So I think if you're an innovator wanting to bring in a device or something unique like brick and mortar pharmacy, which we brought in to this organization, you have to find those that are delivering a health plan outside of the traditional format. And that's really third-party administrators then, and not BUCAs, that are willing to say, yes, because we believe there will be a volume of business come because of it, or there will be a reduction in cost because we use it, that they can decide to use it even though, and put it within the health plan. But then the next hurdle is, what is the provider going to do with it? How are they going to use it? So self-funded health plans that have clinics then have their own internal providers, and they can actually utilize those services within that clinic. And we're talking very seriously about bringing in a unique startup company to bring in called Hero, that would be unique, coming in and managing diabetes within our population by using some very unique methods and how they would do that. So we are willing to innovate, and even within our clinics, we're talking about possibly bringing in some unique devices that could be used. In the past, there's just not been a whole lot of organizations like ours, to be quite honest, to be quite fair, but there are more like us all the time because we're finally breaking the mold, and it's happening.
Well, thank you all for joining us. These folks will be here all day. If you have other questions, please feel free to grab them and drag them out into the hallway. So thank you, and our next group will be up shortly.